So the prevalence of the type 1 diabetes is less than 5% of all individuals with the diabetes, 0.001% of the total population, high rates in the northern Europe and low in the Africa, mostly in the younger years, but can occur at any age group up to the 8th decade. That is the important type 1 diabetes. Usually 95.96%. So they occur in the younger age group, maybe 8 years, 10 years, 11 years, 12 years, etc. But it can occur at any age group, even at the age of 60, 70, 80. Also, one may present with the type 1 diabetes. Symptoms, there are mostly the symptomatic type 1 diabetes, always the symptomatic, or your classical 3 P's will be there here, the polyuria, polydipsia and polyphagia, and also the unintentional weight loss is also very common with the type 1 diabetes. Microvascular complications are not seen at the presentation and 50% present in the diabetic ketoacidosis. So this is a natural history of the type 1 diabetes. The preclinical autoimmunity usually asymptomatic, but once the clinical onset, they are all symptomatic with the polyuria, polydipsia, unintentional weight loss, and insulin dependence. They need the insulin here to control the blood sugars very effectively. Otherwise, they will land up with the diabetic ketoacidosis. So the remission is possible in some cases. That is the honeymoon phase after the initiation of the insulin therapy. So some people, they may have a remission. So that is the honeymoon phase. And then acute and the chronic diabetes related complications, the late standing diabetes is also common at a later time. So staging of the type 1 diabetes, stage 1, 2, 3. The stage 1 is autoimmunity, and normoglycemia, and pre-symptomatic. Stage 2, autoimmunity, dysglycemia, and then the pre-symptomatic. Stage 3, new onset hyperglycemia, and they are the symptomatic. So the diagnostic criteria in the stage 1, in normoglycemia, pre-symptomatic autoimmunity, there are the multiple autoantibodies like insulin antibodies, pancreatic antibodies, islet cell antibodies. So these are very common antibodies will be seen in these individuals with type 1 diabetes because it's an autoimmune destruction. No IgT or IFG here. In stage 2, it's the multiple autoantibodies. This glycemia, that is IFG and the IgT. So the fasting plasma glucose 100 to 125, 2 hours 140 to 199, A1C 5.7.2, 6.4%. Clinical symptoms, diabetes by the standard criteria is all seen in the stage 3 individuals. What are the risk factors for the type 1 diabetes? Genetic factors, environmental factors, and mostly in countries like India, infections also play a major role, like Epstein-Barr virus and other viruses which kill the damage the beta cells, and then there will be the insulinopenia and insulitis, then leads to the beta cell functional loss, leads to diabetes. Elements in the pathogenesis of the type 1 diabetes. See here, there are the susceptibility genes and environmental triggers. So these agents, some environmental factors, act on the genetically susceptible individuals to have a immune destructive mechanisms. So this immune destructive mechanism will cause beta cell dysfunction, so beta cell inflammations, so beta cell fatigue, beta cell death, that is insulitis, then leads to the chronic hyperglycemia and diabetes. The genes involved in the type 1 diabetes are HLA genes, or insulin gene VNTR, superoxide dismutase G, CTLA4, KIT locus. So genes and the type 1 diabetes, the several genetic loci have been associated with the type 1 diabetes risk, of which HLA confers the greatest risk. HLA susceptibility. So DQ8 LLA associated with the DR4 and DQ2 LLA associated with the DR3. So they predispose to the type 1 diabetes. Whereas DR2 and the DQ6 alleles, they protect against the type 1 diabetes. So this is the pathogenesis of the type 1 diabetes. See, during the development of the type 1 diabetes, antigen presenting cells residing within the pancreas process and present the beta cell peptides on the MHC class 1 molecules. These APCs, that is the antigen presenting cells, bearing these peptides, travel to the pancreatic lymph nodes where they initiate an immune response that includes the activation of autoreactive CD8 T cells and autoantibody production by beta lymphocytes. Pancreatic beta cells expressing immunogenic peptides on MHC class 1 surface molecules are targeted for destruction by autoreactive CD8 T cells. Cells of the innate immune system, that the macrophages, natural killer cells, and neutrophils, exacerbate the beta cell death and inflammation through the local release of the cytokines, chemokines, and reactive oxygen species. Beta cells participates in this process. Autoantibodies, they are the insulin antibody, ICA, GAD65, ICA 512, IA2, and zinc transporter 8. So out of them, GAD65 antibodies are very, very important. So they persist for a longer time, also found in the LADA. The insulin antibodies, they found predominantly below the age of the 5. ICA, that depends on the duration of the diabetes, short-lived. Whereas the GAD65 antibodies persist for a longer time, also found in the LADA. And ICA, they islet protein tyrosine phosphatase. So zinc transporter 8. So these are all the different autoantibodies. So autoantibodies are the markers of the immune activation, but do not play an important role in pathogenesis of the type 1 diabetes. A significant proportion, nearly 30% of Indian patients with the type 1 diabetes are negative for all known pancreatic autoantibodies. So some viruses are associated with the type 1 diabetes, RNA and the DNA viruses. RNA viruses, the family picovirus, retrovirus, togavirus, parabixovirus, and retrovirus. So the viruses names are Coxsackie B4, retroviruses, rubella, mumps, retrovirus. So these are having an immunological destruction of the beta cells, so leading to the type 1 diabetes. DNA viruses, you have the parvo and the herpes. Parvo is the Kilham-Rats virus, where the hepatitis virus or cytomegalovirus, Epstein-Barr virus, varicella zoster. See that the general features of the type 1 diabetes, the abrupt onset. So as I told you that it is a symptomatic diabetes. So all the symptoms will be there, the classical 3 Ps plus unintentional weight loss. So the parents, there is a clear-cut indication to their parents to consult a doctor, a physician or endocrinologist about the health of these children. So sometimes, most of the times, they consult a pediatrician because the age group less than the 15 years of age group are seen by the pediatricians. So the non-obese, the people are non-obese here, they are even the lean, very high blood glucose levels will be seen here, 600, 700, etc. Prone to ketosis if left untreated. So decay is very common here, which may be the presenting feature and sometimes a killer also. C-peptide test shows the absence of the pancreatic beta cell reserve, and pancreatic autoantibodies may be the positive, and patients require lifelong insulin for the survival of the health. See the female 48-year-old, male 48-year-old, he was diagnosed to have the high blood glucose 3 months ago. No family history of the diabetes. Weight is 56 kgs, height 174, BMI is 18.49. His fasting blood glucose 198, postprandial 286, A1C 9.2. Taking glimepiride 4 mg per day and metformin 15 mg per day for the past 3 months. He says his blood glucose remains the same for the last 3 months. So that shows that he is not under good control. The fasting is more, postprandial is more, and interestingly, the average, which is supposed to be 6.5, is nearly 9.2%. So what is your diagnosis here? So the diagnosis here is with a normal body weight or a lean with very high blood sugars in a 40-year-old male taking the sulfonylureas and the metformin, but his blood glucose remains the same for the last 3 months. So the blood sugars are the normal here. So what is your diagnosis?
Type 1 diabetes.
So is it a type 1 diabetes? Okay. What are the points to say it's a type 1 diabetes? Age is against. Age usually it occurs in less than 15 years of the age group. Here it is 48 years old.
LADA. No family history.
No family history of the diabetes. Yes, that is goes in favor of the type 1 diabetes and the LADA. Yes.
Lean.
He is not overweight. BMI is 18.
And BMI is 18.49. Ideal.
Is against the type 2 diabetes, more in favor of the LADA. His fasting and the
In
BP are
spite
very
of,
high. HbA1c is also very high. That shows a lot of destruction of the beta cells are done. So he's taking
in spite of taking metformin and glimepiride,
for the last
not
3 months,
regressing.
in spite of the good amount of the OHS. So the glimepiride 4 mg, the maximum dose is 8 mg. We use it. So the 4 mg is the maximum dose, 50% of the 50% of the maximum dose. The metformin is also good dose, but still the sugars are very, very high. His blood glucose remains the same for the last 3 months. So what is your diagnosis? The diagnosis here is more of insulin deficiency, not the insulin resistance. So what test will confirm the diagnosis? So when you are thinking of the type 1 diabetes, so C-peptide confirm. Yes, and also GAD65 antibodies also get it. And other antibodies. So how will you manage the patient? So stop using the glimepiride and the metformin and start using the insulin here because of the glucose toxicity, because it's losing the weight. So once you start on the insulin, so it's an anabolic hormone, they gain weight also. And also the sugars also will be under good control. So this is the slowly evolving immune mediated diabetes of the adults. Slowly progressive form, also called type 1.5 diabetes, autoantibody positive. So GAD65 antibodies will be positive here. Age at onset more than the 40 years of age group. Lean in insulin treatment may not be required for about 1 year or so of the onset, unlike the classical type 1 diabetes. But many patients with the type 2 diabetes who are lean, have no family history of the diabetes, and who require insulin relatively early in the course of the disease may actually have slowly progressive type 1 diabetes. In contrast to the type 2 diabetes, the leading cause of the mortality in type 1 diabetes is nephropathy. This is in part due to the long duration of the hyperglycemia that they accumulate. So the management of the type 1 diabetes, the diet and exercise to some extent, but insulin. So the insulin is very, very important integral part in the management of the type 1 diabetes and the LADA, because insulin is needed here to survive the individual. If left untreated with the insulin, these people will present with the DKA also. So the DKA is a medical emergency, and sometimes there will be high mortality because of the DKA also. So in all these in type 1 diabetes, so once the diagnosis is the type 1, once the diagnosis is the LADA, so definitely they need insulin for their survival. So treatment start with the soluble insulin, 2 to 4 doses depending on the severity. Total dose varies from 0.5 to 1 unit. per kg body weight per day, adjust by frequent glycemic assessments. Multiple dose insulin therapy covering both basal and the prandial insulin requirements is preferred. So usually, in type 1 diabetes and the LADA, we have to give the most physiological way of introducing the insulin. So that means 3 shots a day or 4 shots a day is always needed in these individuals. See, the most patients with type 1 diabetes will need multiple doses of insulin per day. So if you see first picture, so there are about morning regular to cover the blood sugars following the breakfast. Then the afternoon regular insulin to control the blood sugars following the lunch. And then the evening times again to control the blood sugars caused by the dinner. And then the night time you have to give the NPH insulin or the basal insulin like glargine or the Rituxan, the deglutide. So to control the basal hyperglycemia. So the multiple daily injections are very much needed. They generally consist of 1 injection of long acting insulin and 2 or more shots of the short acting insulin. If finances permit, glargine or the Rituxan can be advised as the basal insulin. This has the advantage of more predictable action profile and less chance of the hypoglycemia. Similarly, rapid acting analogs can be advised as the prandial insulins due to the more flexibility in timings and lower risk of the late hypoglycemia. So definitely the analogs are very, very useful in treating the hyperglycemia caused by the type 1 diabetes. Of the total dose may be given as the basal insulin, usually at the bedtime, and titrated based on the fasting blood glucose values. The other 50% may be divided among the main meals of the day based on the post-meal blood glucose values. Regular SMBG and patient education is a must for the success of the multiple daily injections. So the pump is also there. It is an attractive or therapeutic option for many patients with the type 1 diabetes, but the cost is a big negative point for the usage of these pumps in most of our type 1 diabetic individuals. So SMBG, it is recommended that patients with type 1 diabetes check their blood glucose several times per day. So this is how they have to go for. On the Monday, 3 times, Tuesday, maybe the 4 times, Wednesday, 3 times, etc. But in Indian population, you can give some more concession that Monday fasting, Tuesday after breakfast, Wednesday before lunch, or Thursday after lunch, Friday before dinner, Saturday after dinner, and Sunday at about 3 a.m. That's how we can get the SMBG also from most of our population. The same thing here. So adjustment to the morning injections. So if the persistent hyperglycemia is there before the lunch, increase the fast acting insulin in the morning by 2 units. So if the persistent hyperglycemia before the dinner, then increase the intermediate acting insulin in the morning by 2 units. If hypoglycemia occurs without explanation, so reduce the fast acting insulin in the morning by 2 units. So the same thing here after dinner and before the breakfast. Honeymoon phase, a partial remission of diabetes following the initiation of the insulin therapy. So once you start the insulin therapy, so they gain the body weight, they gain the good well-being. So there may be a chances of having the regaining of the lost function in their own pancreas. So they characterized by the abrupt reduction in the insulin requirements, rare in adult onset type 1 diabetes, usually lasts only for a few weeks. Patient should be warned not to stop the insulin, because here insulin is very much needed for the survival of the individual. Challenges in managing the type 1 diabetes in India. The many patients are unable to afford the medications and devices needed to manage the diabetes. Many do not have the necessary facilities at home to store the insulin at the right temperature. They face issues during the schooling and while seeking the employment. They often face the difficulty in finding a life partner. So that finishes our type 1 diabetes. Then we'll move on to the drug-induced diabetes. Mechanism of the drug-induced hyperglycemia. Here, with the decreased insulin secretion, some drugs may increase the insulin resistance also. So what are the drugs which reduces the insulin secretion? So the beta cell toxins like pentamidine, streptozotocin, reduce the insulin release, thiazide diuretics, digoxide, somatostatin, etc. The drugs which increases the insulin resistance are the steroids, estrogens, diuretics like thiazide diuretics, beta blockers like your propranolol or atenolol or metoprolol, but not with the carvedilol and bisoprolol, clonazepam, vonazepam. So they are very much useful drugs. Glucagon increases the blood sugars very fast because it causes hyperglycemia, growth factors. So these are also very important. So the decreased insulin secretion and increased insulin resistance. Thiazide-induced diabetes found with the use of the high doses of the thiazides, more than the 5 milligrams per day, or more 25 milligrams per day of hydrochlorothiazide. 3 to 6 cases per 1000 patient years when such high sugars are used. Risk is minimal with the lower doses. Glucose intolerance develops slowly with a mean lag period of the 2 years. Relative risk is more in the males, closely related to the degree of hypokalemia produced by the drug. So thiazide diuretics, the potassium depletion, reduced cleavage of the proinsulin to the insulin. So the postprandial hyperglycemia and elevated permission proinsulin levels between the meals, downregulation of the peripheral insulin receptors, insulin resistance. Here they reduce the insulin secretion, then the diabetes. Beta blockers are very much useful drugs, especially in the cardiology practice. So in the heart failure, we use the beta blockers. Post CABG, post PTCA, post myocardial infarction, we use the beta blockers as they reduce the mortality, and they are not only good, so they are very, very useful also. Beta blockers reduce the insulin secretion, increase the hepatic glucose output. Non-selective beta blockers can also impair the sympathetic responses to the hypoglycemia. Effect of the beta blockers on glucose metabolism depends on the lipophilicity of the particular agent. Steroids are very, very useful drugs. The steroids may cause the diabetes. So steroids impair the hepatic and the peripheral tissue sensitivity to the insulin. All glucocorticoids can produce the dose-dependent glucose intolerance at doses more than the 7.5 grams per day of prednisolone or its equivalent. Rapid onset to the glucose intolerance not related to the duration of the therapy. Usually reverses on the withdrawal of the drug. Mostly found with oral and injectable preparations, are very rare with the inhaled preparations. Can occur with the topical preparations applied over the damaged skin over the large area with the occlusive dressings. So endocrinopathies associated with the diabetes, the type 2 diabetes are associated with the acromegaly, Cushing's, hyperthyroidism, Frio, hyperparathyroidism, glucagonoma, VIPoma, or somatostatin. Whereas the type 1 diabetes is associated with Addison's disease, Graves' disease, hypothyroidism, and primary testicular failure. So these are associated with the type 1 diabetes. And other associations, PCOS, diabetes insipidus, diabetes mellitus, optic atrophy, deafness syndrome, growth hormone deficiency. So thank you very much for your patient hearing. So over to you, Ankit. The most specific congenital anomaly seen in infant of a mother with diabetes Most specific,
Sacral agencies.
yeah, sacral agencies. But most common is neural tubal defects.
Neural tubal defects.
28 weeks pregnant lady undergoes a glucose tolerance test with 75 grams glucose. Blood glucose levels 86, 188 in the first hour, 138 second hours. What is the diagnosis? So one out of these three abnormalities considered as the gestational diabetes. So 0 hours 93, first hour 180, second hour 153. So here it is first hour 188, more than 180. So that shows gestational diabetes. So right answer is C, gestational diabetes. Next slide. Which of the following agents is not approved in the pregnancy? Regular insulin, yes. NPH insulin, yes. Insulin degludec, yes. Insulin detamers. So nowadays, all the four are approved. All the four are approved. Even degludec is also approved right now. Earlier, it is the degludec was the right answer. Then the fourth one, which of the following is false regarding the honeymoon phase of the type 1 diabetes? Characterized by the greatly reduced insulin requirements. It is due to partial beta cell recovery. It lasts only for a few weeks or the months. It is more common in the adult patients. No. 4. The false here is D. D. It is characterized by greatly reduced insulin requirements due to partial beta cell recovery. It lasts only for a few weeks or the months. Again, the people will have a diabetes. So it is only honeymoon phase. The D is the wrong answer here. Which of the following endocrinopathies associated with the type 1 diabetes? Type 1 diabetes. Acromegaly, Cushing's, pheochromocytoma, Graves' disease. Graves' disease. Graves' disease is associated with the type 1 diabetes. Antibodies. Thiazide diuretics induce hyperglycemia by increasing insulin resistance, reducing insulin secretion, both or neither. Mostly by increasing the insulin resistance, to some extent and reducing insulin secretion. So the right answer is the C, both. Next one. Which of the following cannot cross the placental barrier? So glucose can traverse, amino acids can, ketones can, but not the insulin. So right answer is the D, Dilly. Which of the following oral anti-diabetic agents can be continued during the pregnancy? Metformin, you can continue. Glycoside, stop it. Pio, stop. Ceta, stop. So right answer is the A, metformin. Which of the following diabetic complications does not worsen during the pregnancy? Diabetic kidney disease, worsening. Neuropathy, retinopathy, all of the above. So the diabetic kidney disease and the retinopathy can worsen, but not the neuropathy. Insulin requirements the maximum during weeks of the pregnancy. Between 32 to 36 weeks of the pregnancy. Insulin requirement is the maximum. And after the 36 weeks, the insulin requirement will be reduced to some extent. Okay. Thank you, Ankit.
Thank you, sir. Thank you so much. Thank you for the wonderful session.
Okay.